You will go to next case, Ahmed Qasim from Saudi Arabia, a case of a stent fracture. وين أحمد قاسم؟ مش موجود؟
دكتور أحمد قاسم.
Okay, next case, Islam Shah from UAE, journey from tear to seal and heal. It's nice, like music. I have supporter as well. Please take a note of each case.
Hi everyone and Assalamu alaikum. I am Dr. Islam working as a specialist intervention cardiology in Al-Qasim Hospital, Sharjah, UAE. First of all, I am glad that I will have more time because the one speaker is absent. I have a challenging case and my topic is how to approach the threat. And if you have a tear during an intervention, how to seal it in order to give them chance to heal. During a talk of Antonio in the morning, there was one participant who said a very good words that failure is better in the learning as compared to success. But my story case is both. So hopefully we will learn more from this. I have this 56-year-old gentleman. He's hypertension and dyslipidemic, and he was on chronic medication. He was admitted to our facility as an STEMI. His lab investigation was fine, including cholesterol, and troponin was 939. This is high-sensitive troponin. X-ray examination was fine, and the ECG showed deep GVM inversion in the anterolateral and inferior leads. And from the ECG, we thought it must be the LAD. The echo in difficult cases, usually everything is difficult. It's a difficult windows, but it clearly shows a hypokinesia of the septum, apex, and ejection fraction 45% by Simpson. So we pushed the patient for angiography because he has an STEMI and in view of STT TVM inversions and the echo findings. The right system was found dominant and normal with good PDA and PLB branch. We were not surprised by the left system because that's what we thought that it would be. As a severe calcified lesion from osteoproximal to mid involving the diagonal ostium. And the circ was okay. So before jumping to any procedure and intervention, we plan what to do. We plan that we will do imaging with the OCT, and then lesion preparation with the rotablation, balloon, and plus minus intravascular lithotripsy if needed, and then provisional stenting strategy for the stenting. So we have a difficulty from the start, and our OCT catheter was not able to cross the lesion, and it was looping backward. So we went to the next step, and we used the rotablation, 1.25 bar with multiple runs. And after rotablation, our result was satisfactory, and we were able to cross the OCT wire and catheter. This is a post-rotablation OCT, and if you can see, there is a deep calcification 360. So what we think that this lesion need more preparation, and we went to the next step and having intravascular lithotripsy. We took 2.512 lithotripsy balloon to the mid segment and 3 and 12 lithotripsy balloon to the proximal, and we did multiple sessions of lithotripsy. After lithotripsy, we were very much happy because the lesion was treated good and prepared good, as you can see. But if something is wrong, can anyone comment? Yeah, great. So you took it. So if you can see, the distal, very distal LAD there's a tiny perforation, and most probably it is spilling to the cavity. So now we have a challenge. We have a distal perforation, and we already prepared the lesion. So what will be the next step? Either to treat the perforation first or to treat the lesion first. Is there any comment? No. So we went for the stent implantation to treat the lesion first, and we implant into drug-eluting stents, Zynis Sierra 2.523 and 3.538 from osteoproximal to the LAD overlapping. And this was the result. After stent implantation, there was something more wrong. And if you see, we lost the large diagonal. So now we have a challenge to treat the diagonal also and to treat the perforation also. But we decided to go for the perforation first and to seal it. But how to seal? Is a very distal, to seal it with a balloon or coil embolization. Anyone can comment if coil embolization, because it is very distal. So we stretch our shoulders and we embolized 4 coils, 2 into 15 C stopper to the distal LAD, and we were happy with the result because there is no apparent leaking anymore. And we were then attempting the diagonal. We were trying our best with the multiple wires and microcatheters, and we were almost partially successful to just have a TIMI 1 flow in the diagonal. But something horrible happened, and patient went into hypertension and tachycardia. So we put our echo probe, and we did bedside echo, and we noticed that the patient is tamponading. So we were happy that our coil worked, but probably not, because the patient is tamponading. We put a subzified approach and put a pectoral catheter, and we removed 800 cc of blood during almost 20 minutes, but it was pooling again, and it was not stoppable. So now we have a challenge that we lost diagonal already, and the patient is tamponaded. So what would be the next step? So always thanks for a help and call the surgeon. We called the surgeon, and they shifted the patient to the operation theater, and they found a big clot removed from the pericardial sac, partly interior and partly behind the heart. And the blood, they found the blood was spurting from a very tiny distal LAD, and they sealed with a proline. And they grafted a diagonal. Post-surgery, the patient troponin went from 900 to 7,000, and it dropped to 2,000 after 48 hours. The hemoglobin, he received 2 units of blood during the surgery, and after the surgery, 1 unit. His creatinine was 77, and he has a very good urine output. Post-surgery ECG was good. There was little imputation of the QRS, but otherwise it was good. X-ray was fine.
Yes, give us the just last.
I have just 1 minute, please.
No.
Yeah. Okay, so what the learning points from my talk? Take care of the distal tip of the wire. It's very important. Always hold the wire while injecting, especially with a pump. It can perforate the distal. Early recognition of complication is critical. Critical thinking and decision making is very important. And don't hesitate and ask for help. Thank you.
Thank you very much. Ahmed Imam, your input,
Thank
please.
you very much for sharing this case with us. But I want to ask you why you choose to stent the lesion and deal with the lesion before dealing with the perforation. I think perforation is an emergency situation, and you should deal first before stent. Especially you have TIMI flow and there is no thrombus, nothing in the lesion. You give time to patient to get into tamponade.
I think the approach will always be divided in this situation, but our patient was stable. He was not hypotensive. We did the echo actually bedside. There was very thin rim.
He will eventually collapse. He's stable, but he will collapse. You give him time to collapse. So I think it's better to deal with the perforation.
I take your advice positively. It can be done like that, but we went to put the stents first and then did coagulation later.
Can I just add, I think I agree with this comment, because when you put the stent, you're increasing the flow. You have a hole at the end of the artery, you increase the flow, so the leakage is going to be much more. And one more thing, sometimes coils are not the best thing for arteries like this. You could use collagen. You could use the angioseal that you use for your for closing the femoral artery. Break it, take the collagen, cut it in small pieces, put it in contrast, and then you could inject it through the microcatheter or, the heart rail, the old guide extension.
Yes,
Yeah,
just
that is
to add
another
to
option,
that,
sure.
with the perforation, it's one word bad. You block and deliver. So you block you open the artery instead of block it. You block it with a balloon, then you deal with the perforation first. Yeah, I think so.
That can be another strategy. Thank you.
Thank you.
دكتور
Thank you.
القحطاني half minute بس.
Less than half a minute. Just going back to the collagen point there. Delivering things like through microcatheter is not very easy. I had cases where I had to embolize fat in those situations by using an export catheter, and not microcatheter, and that by applying some negative pressure on the port where you suction the clot and load the fat, and then you deliver it and you inject it. I want to know your experience with microcatheter. It was very difficult to deliver things because it's so small. So I just want to hear back.
Sorry, it's not microcatheter. You cannot deliver it. You use an heart rail, which is, I said, the old over-the-wire guide extension. That's how you could deliver it.
Dr. Islam Shah, thank you very
Thank you.
much
Thank
for
you so
your
much.
case. Thank you.